Hello everyone, welcome to the Decabyte series and welcome to Decabyte number 3, which is on stroke and TIA. Without wasting any further time, let's jump straight into it. Firstly, we have Hippocrates, who coined the term stroke, which means struck down with violence. Now, to understand strokes and TIAs, we need to have a very sound understanding of the anatomy of the brain and the blood supply of the brain. So, coming to the anatomy of the brain, we have four different lobes here. We have the frontal lobe, which is associated with personality and social behavior and understanding. We have the parietal lobe, which is associated with motor and sensory movements. We have the temporal lobe associated with hearing, and the occipital lobe, which is associated with vision. We have a sulcus or a depression here, which is called as the central sulcus. The area before the central sulcus is called as the motor cortex, which gives rise to your corticospinal tract, which is the motor tract in our body. And the area behind the central sulcus is called somatosensory tract, or somatosensory cortex, where the sensory tracts end. We have the Broca's area, which is located in the inferior frontal gyrus region, which is associated with speech. We have the Wernicke's area, which is located in the superior temporal gyrus region, which is associated with comprehension or understanding. And we have a band of fibers here which connect the Broca's and Wernicke's area, which is called arcuate fasciculus. This makes total sense because whatever we hear through the auditory cortex, we understand in the Wernicke's area, transmit the information to the Broca's area so that we understand and speak out. Once we know that, let's come to the blood supply of the brain. On the lateral side, we have the majority of the lateral surface being supplied by the middle cerebral artery, and on the periphery we have the anterior cerebral artery or the medial most side, and on the posterior inferior side we have the posterior cerebral artery. On the medial side, the majority is supplied by the anterior cerebral artery, and on the posterior inferior side we have the posterior cerebral artery. And the brainstem is divided into three parts. This is the midbrain, this is the pons, and this is the medulla. The midbrain gives rise to the cranial nerves 3 and 4, the pons gives rise to cranial nerve 5, 6, 7, 8, and the medulla gives rise to cranial nerves 9 to 12. This is important because suppose we have a stroke in the midbrain, which could be due to any reason, we will have symptoms of third and fourth nerve palsy. So vice versa for every segment. Now coming to the blood supply of the internal surface of brain, which is called circle of Willis. To understand that, we need to understand that the main vessels come from the arch of aorta is the common carotid artery, which divides outside as the external carotid artery and inside as the internal carotid artery. The internal carotid artery goes upwards and goes through the carotid foramen and divides into the anterior cerebral and middle cerebral, which we have just seen. And whereas from the backside we have the two vertebrals which join together to form the basilar artery, which contributes to the posterior circulation. Let's look at the circle of Willis. The circle of Willis has two arteries. The two vertebral arteries from the backside join together to form one basilar artery. The basilar artery ascends upwards and divides into two posterior cerebral arteries on either side. And once that is done, you have the intercarotid artery coming from the front, dividing into middle cerebral artery and an anterior cerebral artery. And the two anterior cerebral arteries are connected by the anterior communicating artery, whereas the middle cerebral artery on one side and the posterior cerebral artery are connected by the posterior communicating artery. This forms a total circle, which is called as the circle of Willis. The circle of Willis also helps us to understand the blood supply of the brainstem. The posterior cerebral artery is the main supply to the midbrain, whereas the pontine arteries, as the name says, is the main blood supply of the pons, whereas the pica, the posterior inferior cerebellar artery, and the anterior spinal artery, these two are the main blood supply of your medulla part of the brainstem. Once we know that, let's talk about the homunculus. Homunculus is nothing but a topographical representation of the arrangement of the body parts upon the primary motor cortex, right? By knowing the homunculus, while looking at the signs and symptoms clinically, we can say which artery is involved. For example, if according to the homunculus, on the motor cortex, up the uppermost part we have the lower limb, that is the hip and trunk, then we have the upper limb, that is the arm and head, then we have the face, then we have the tongue, then we have the voice box or the larynx. So suppose a patient presents with symptoms of right lower limb weakness, we know that his left ACA might be involved. And if a patient presents with right upper limb weakness, his left MCA might be involved. If a patient presents with weakness in swallowing or anything, then again we can say that his MCA might be involved. That is the importance of homunculus. Now we know that, let's talk about the different tracts we have in our body. We have one motor tract in our body, which is called as the corticospinal tract. As the name says, it starts in the cortex and ends in the spinal cord. It starts off in the motor cortex, primary motor cortex. This neuron which starts to come down is called as the upper motor neuron. The upper motor neuron descends through the midbrain, through the pons, and then it crosses to the opposite side in the medulla. A similar sort of thing also happens on the opposite side, and therefore this looks like a crossing which is in the shape of a pyramid, and therefore it is called pyramidal decussation. Once the pyramidal decussation occurs, it goes to the particular spinal segment which muscle has to be moved, and it synapses with one more neuron which is called as the lower motor neuron. So we have two neurons here, neuron number 1 upper motor neuron and 2 lower motor neuron. So suppose if a patient is not able to move a muscle, it could be due to three reasons. One, damage in the brain, damage to the upper motor neuron, or damage to the lower motor neuron. But in strokes and TIAs, we are assuming the damage mostly to be in the motor cortex or the brain. The next part, let's look at the two sensory tracts. We have in red, in blue, we have the spinothalamic tract, and this is associated with sensations of pain and temperature. In red, we have the dorsal column medial lemniscus pathway, which carries all sensations except pain and temperature. The main difference is the crossing. Now let's look at the spinothalamic tract in blue. The spinothalamic tract, as you can see here, it is entering from the receptor and in spinal segment, and it crosses immediately. It crosses immediately in the spinal cord without ascending, and therefore eventually it ends in the sensory cortex. Whereas if you look at the dorsal column medial lemniscus pathway, it is crossing, it enters into the spinal column but does not cross immediately, it goes upwards. This ascending pathway is called as the dorsal columns, and then it crosses in the medulla to the opposite side, and this crossing is called as a medial lemniscus. Therefore the name of the tract is dorsal column medial lemniscus pathway. The crossing occurs at the medulla just like the corticospinal tract, and eventually it is also going to end in the sensory cortex. So the point is, crossing of all tracts occurs in the medulla except for the spinothalamic, which occurs at the same segment of the spinal cord. Once we know that, let's look at the different types of strokes we have. We have a hemorrhagic stroke where blood is spilled over the brain. We have an ischemic stroke where the blood is deprived of the brain is deprived of blood. The risk factors for hemorrhagic stroke are hypertension, where you have a high blood pressure leading to rupture of the blood vessel, and berry-aneurysm rupture. Berry-aneurysms are nothing but saccular or fusiform dilatations which are seen most commonly at the junction of anterior communicating artery and the anterior cerebral artery. When they rupture, you will have something called as a subarachnoid hemorrhage, and the patient will say that he is having the worst headache of his life. The risk factors for ischemic stroke or anything which causes atherosclerosis or a high fat diet, and atrial fibrillation is also a big risk factor because it predisposes the patient to develop clots, and these clots will be traveling upwards to the brain and become a risk factor for an ischemic stroke. Now that we know the risk factors, let's calculate how to assess the clinical features for score, which we do with the help of the Rosier score. Each factor is given 1 point and subtract 1 point, as you will see here. Facial weakness is given 1 point, and blurring of vision or visual field defect is given 1 point. Any kind of speech disturbance is given 1 point. Leg weakness is given 1 point. Arm weakness is given 1 point, and any history of syncope you subtract -1 point, and if any seizure occurred, then you subtract -1 point. If you have a Rosier score which is even 1 or greater than 0, it is significant. Now let's come to assessing the TIA with the help of an ABCD square score. The difference between TIA and stroke is that TIA is a subset of stroke where the symptoms develop and resolve within a period of 24 hours. The A of ABCD square score stands for age, which is greater than 60, which is given 1 point. The B stands for BP greater than 140/90, which is given 1 point. The C stands for clinical features, which could be speech disturbance, which is given 1 point, or unilateral weakness, which is given 2 points, arm or leg weakness. And the D stands for the duration, which is less than 1 hour, is given 1 point, greater than 1 hour is given 2 points, and the second D is diabetes, which is given 1 point. If you have a total score greater than 4, then it is significant and needs intervention. Once we know how to assess the scores, what intervention is the primary modality? It is a CT scan. Anything which is white on the CT scan is blood, and anything which is hypodense on the CT scan is lack of blood, which is ischemia. So as you see here, there is hypodensity in this region, which is involving a little bit of frontal, parietal, and a little bit of occipital lobe. So left MCA ischemic stroke. And as you see here, there is hyperdensity in this region, which is white blood. This is an example of right MCA hemorrhagic stroke. And as you see here, there is blood here, whitishness here in the shape of a star. This is an example of the star is because of the circle of Willis, and this is could be due to a rupture of berry-aneurysm, and this is an example of subarachnoid hemorrhage. Now in trauma, we will also see two other kinds of bleeding commonly. This is called a lens shaped or a biconvex shaped or a lemon shaped bleed, which is nothing but your extradural or epidural hematoma, which is due to rupture of the middle meningeal artery. Whereas on this side you will see this crescent shaped or banana shaped bleeding, which is occurring due to rupture of the bridging veins, which is because mostly it is called of subdural hematoma, and this is mostly in old people who have fall or who have whiplash injuries, etc. Once we know how the CTs look, let's see how do we actually manage the patient. The first thing to do is to always check sugars. Hypoglycemia mimics stroke, therefore correct it before you send the patient to CT scan. Number 2, do not reduce the BP so easily. If you have to reduce the BP, make sure that SBP is greater than 220 or the diastolic blood pressure is greater than 120, and the best agent is IV labetalol, and target a BP reduction of about 10 to 25% in the first hour. This is taken from Tintinelli. And if the oxygen saturation is less than 94, put him on oxygen. Perform a swallow test if it is possible with a teaspoon of water. Go ahead and get the CT scan done. If the CT scan shows no hemorrhage or no whitishness, assume that there is ischemia, though you might not see hypodensity very clearly because CTs don't pick ischemia so easily. So go ahead and give the aspirin if there is no hemorrhage. Give 300 milligrams per orally if the patient can swallow, per rectally if the swallow test is negative, which you had done just before. And if the patient is allergic to aspirin, go ahead and give him clopidogrel 300 milligrams. If the patient falls within the window period of 4 hours, or some books say 4.5 hours, you will go ahead and give him the thrombolytic, which is altiplase. The dose is 0.9 milligram per kg, of which 10% will be given as bolus, and remaining you will give it over an infusion of 1 hour. Admit the patient to the stroke unit. Of course, all of this will be done in the presence of the neurologist. Admit the patient to the stroke unit. Now, for TIA people, if the ABCD square score is greater than 4, you admit the patient, and if the score is less than 3, then you discharge the patient with tablet aspirin 300 milligram for 1 week, and after 1 week you ask him to review with neurology. So I hope this Decabyte has helped you and made some difference to you. I thank you for your time. I will see you next time with my next Decabyte. Bye bye.